If you're a vein specialist in the United Kingdom and you're thinking about going into private practice, you're in the right place. Today, I'm going to be talking to Martin Claridge, who's an expert consultant vascular and endovascular surgeon in Birmingham. I don't know how he does it, but he combines an extremely busy NHS practice treating people with venous disease and arterial problems. He has extensive management and leadership roles within the NHS, and he runs a CQC-registered private clinic treating veins. I'm going to be talking to Martin about the various models of private practice in the United Kingdom, pros and cons for each. I'm going to be asking him about his motivation for going into private practice and why he chose to set up his own private clinic. And be sure to stay to the end, where Martin gives very sound advice to newly appointed consultants about private practice. And this advice is applicable to other specialties such as dermatology, ophthalmology, you name it. So let's get started. Let's dive in. Tell me, is there anything that you don't want to talk about?
Well, I suppose it depends what you're going to ask me, doesn't it? But no, I'm quite happy to talk the business side of things as much as I can. I've been doing this for a while, but the more I talk to guys like yourselves, the more I realise I have more to learn than I have to offer. And certainly stepping into the sort of commercial side of things has been quite hard work at times for me, and particularly recently where people have come directly at me, which I suppose is a compliment somewhere in that. I suppose I probably wouldn't want to talk about the negative side of that. I don't know necessarily if that's what you want in a podcast anyway.
No. Listen, we don't need to name
or the advert.
We don't need to name anybody because we're a small group of people doing private practice anyway. We'll know who the people are, but we don't need to name them and publicise it.
Sure.
And any of us in private practice know that there's somebody down the road who's, in quotes, a competitor. But in reality, here's what I think, and it's an eye-opener from me, from Chris Pittman. Do you follow him on LinkedIn?
A little bit, yeah. I mean, I think I've heard some of the things he's got to say, yeah.
Yeah. Well, one of the things that he said, which was a real eye-opener for me, was that we who treat veins don't have any competition. We don't, because the demand for vein treatment in the UK is huge, absolutely huge. And he makes the comparison between spectacle wearers and opticians and people with tooth problems and dentists. There's a dentist in every small town. I live in a town that's got about 8,000 people in it, and we've got 4 dentists and we've got 5 opticians. And there's the venous disease is almost as common. So we're not really in competition with anybody, though sometimes it feels like it, doesn't it? It feels like we've got a competitor down the road, and we haven't really. All we need to do is keep ourselves focused on what we do.
Well, and that's very much I've seen as well, actually. So I was quite surprised when I had that sort of a recent move at me, which is not something I've always, I suppose some people describe it as co-opetition, don't they? You all work together. And as you said, and most people feel there's enough to go around. And if you look differently at it, then it tends to consume you somewhat, I think, as well. So you start navel gazing rather than thinking about the sides of it. So yes,
exactly. So I think what I'd like to do really is to open up the discussion for other people, perhaps who are in private practice, not only veins. I mean, there might be dermatologists or ophthalmologists, orthopedic surgeons. I think orthopedic surgeons are slightly different, but I think there's a lot of people who are thinking about going into private practice. Perhaps they're newly appointed consultants and they're thinking about private practice and wondering whether it's really worth the effort, what are the pros and cons. There'll be people who perhaps are in solo practice and thinking, should I form affiliations and ties with colleagues and form a group? There's some people perhaps who are thinking, do you know what, maybe I'll go full-time into private practice and leave the NHS altogether. So I think having somebody's perspective like you is interesting. And in many respects, Martin, what you have done is pretty awesome. You may not think so, but I think it's pretty awesome. You're an NHS consultant. You've got a busy practice. You're treating people with venous disease and arterial disease in the NHS. You could have very easily just had practice privileges at your local private hospital and done a bit of private work on the side, as it were. Or you could have gone full-time into private practice and decided that the NHS is not for you. But you've done perhaps the most difficult thing ever. You've decided to set up a CQC-registered clinic, be involved in the running of a CQC practice, and combine it with a pretty hefty NHS practice. So, first of all, deep respect. I'm amazed that you can do that, and it's a tribute to your energy and enthusiasm and, I don't know, just general in there, really. I can't find the right words for it. So first of all, I wanted to ask you, why did you go into private practice when you're so busy in the NHS? What attracted you to do some private practice in the first place?
Well, I suppose my interest in taking up and starting a private practice was on a number of reasons. Part of it was some advice I received. Don't put all your eggs in one basket. And one of the advantages of being a surgeon and spending some time in training and developing all these skills and experiences that we've got is that you can use them. And part of that, perhaps, is offering treatment for patients not in just one facility or one sector or the other. And my eyes really were open to that when I was in Australia, where I was on the fellowship for a year, where you saw some really good coexistence of private practice and the government state-funded services there. And also, to be frank, you saw some bad examples of it too. But it made it clear that actually, with clinicians, we can offer patients treatments for different reasons outside of what rules and regulations might be made by a particular health authority or particular governing body. And that as long as you're practicing with your patient's interests at heart, there's a perfectly reasonable reason and it's perfectly reasonable activity for you to look at providing treatment in more than one facility or faculty. In Australia, it's very common to have what they term as a hybrid or portfolio jobs, where you might be working for a state facility, you might be working in your own private practice or a private hospital, you might be working for a university. And I think that's quite common around the world, I'm given to understand. Whereas in the UK, particularly when I came back to start my consultant practice in 2011, it was perhaps less common that people had that type of portfolio roles and portfolio jobs. So that's when my interest started. And then along with that, what I became aware of is that particularly these new techniques in treating varicose veins, which obviously you pioneered and I perhaps came into a bit later, but I trained and worked in an academic unit which pioneered a lot of these treatments, particularly with Andrew Bradbury and his whole team, Gareth Bate, one of the clinical nurse specialists that we still work with. They've really developed and pioneered and demonstrated the evidence for foam sclerotherapy and these walk-in, walk-out keyhole treatments to effectively deal with truncal varicose veins and truncal venous disease. I was aware that the opportunity to offer those techniques wasn't particularly there inside the NHS all the time, or indeed inside private hospitals. So that's what piqued my interest, was to see whether I could perhaps have a portfolio job and perhaps develop some of these techniques and develop perhaps a facility to offer these techniques in an effective way that patients would benefit the most from.
Mm. Well, I understand that entirely, because I'm of a generation slightly before you, perhaps not a generation, but perhaps a decade before you. And I remember the frustration I had in 2002, when it was quite clear that endovenous treatments, both endothermal and foam sclerotherapy, were better than high surgical ligation and stripping. They were a good alternative, and that's what people wanted. We didn't have quite the evidence then, I don't think, but it was quite clear that it was emerging. And we didn't get nice guidelines until 2012, 10 years after these things were being accepted and adopted by vein specialists, vascular specialists. And I felt the difficulty of working in an NHS environment where it was very restricted access to vein treatments, and the access to the treatments that were available were even further restricted to surgical stripping. And that was on the one hand, and on the other hand, but by the way, I could see you privately and do one of these newer treatments. I felt very uncomfortable with that, seeing patients referred by their GP or perhaps by a nurse specialist, an ulcer nurse, and having this, second-class service in the NHS. And for the same reasons, I thought I could offer something alternative in private practice. From the sound of what you're saying, Martin, it sounds like you valued autonomy, the ability to do what you thought was in the best interests of your patients outside the NHS.
Yes, absolutely. I agree with that. And I think, I also value that inside the NHS as well. I like the idea of being able to offer the best that I can for my patients using the evidence base that we have. And I realise that's a slightly evangelical thing for a clinician to say, but you do need to stand up for that, and also perhaps put your money where your mouth is and take on management roles and set and design services up so that you can provide that, rather than perhaps expect someone else to do it for you. But you've also bring people with you, and people want that to be the case, rather than it appear that you're fighting upstream all the time. So, I mean, I do offer the same treatment in terms of venous techniques in the NHS and privately, perhaps for different reasons, but I do offer the same techniques, and I believe offer the same standard of care in both sectors.
That's very good. I think that's something that's changed since I left the NHS. I left the NHS in 2008, and at that time, yes, there was some access to endothermal treatments, but it was regarded as something new. And it wasn't until 2012, when we had the NICE guidelines, that then it became legitimate, as it were. We were following the guidelines and the guidance. Tell me then, why did you not go into practice privileges? Why did you choose to go into the administrative burden and the regulatory burden of establishing your own clinic? Why not just have private practices either within the private wing of your NHS hospital or within the private hospital? I'm sure there's a Bupa or Nuffield hospital nearby that you could just perform your clinical duties privately to a very high standard and have the degree of autonomy that you wanted. Why take all this on?
But I did look at that. In terms of managing private patients inside the NHS facilities in Birmingham, that's a non-starter. At least it was, 10, 15 years ago. Perhaps the quality of the real estate would be not becoming for patients that wish to fund themselves, and bluntly the capacity wasn't there. And so whilst there's always been this desire for the NHS to have a private funded set of patients, and actually it sits inside budget lines still to this day inside the divisions and the directorates, the facility is not there. It's widely recognised that that's not the case in Birmingham. I appreciate it might not be the case elsewhere in the country, but it isn't right for Birmingham at this point in time. In terms of private hospitals, I did look at and do have practicing privileges at some of the local private hospitals in Birmingham, but they're just not set up for it. So I remember going in there the first time to do some foam sclerotherapy, had everything set up I had to do it in an operating theatre, which I didn't particularly like. I don't particularly like the fact that the patients have to get changed into a gown, they get surgicalised, if you like, they get put on a trolley and wheeled in, which I don't think is good for them. They're given long periods of post-operative care where they're non-mobile afterwards, and I think it makes the patients more anxious than they need to be, being brought into an operating theatre. Perhaps as well, not particularly good use of a more complex resource in terms of the facility itself and also the staffing. But I do remember the first cases I did in a local hospital, they brought the patient in, I checked all the equipment was there, I turned around and asked for the foam, and they handed me a piece of foam. And that's literally what they wanted me, because they felt that what I was going to do was bandage the leg up with some foam, and that's how I was going to treat these varicose veins, despite the fact I got everything. So it was clear to me that the expertise wasn't there. I was willing perhaps, but the expertise wasn't. And after talking to the management teams in the private hospitals and explaining what I was doing, they didn't particularly have a huge interest in developing this service. I think perhaps financially for them, perhaps not of great interest. You talk about orthopedic surgeons in the past. I can understand why your private hospitals exist, and the facilities and resources they have might be more appropriately used for more complex procedures in terms of need for anaesthetic and sterile environments and operating theatres and so on. So it became clear to me these facilities weren't there. I did manage to start doing some work in treatment rooms, but I had to bring my own team in to do it. And I found that bluntly I was funding this myself. So out of the funds that or the fees that I would charge, I had to fund the whole team. And the follow-up care and so on. And so it wasn't particularly financially advantageous to do this. But also, you asked me why I still thought about setting this up myself. It became clear to me that the only reason I wasn't doing this myself in my own premises was because of the regulatory burden of registration and whether I was prepared to take the financial and clinical and I guess reputational risk to make that step. So that's where the seed, if you like, was sown. And I was thinking about doing it for a while. And I did talk to some of my colleagues. A lot of them were quite worried and concerned about taking this on and worried whether it should occur or not. Looking around nationally, there weren't that many individuals that had done this. But then we had COVID, and the result of COVID in Birmingham was that, as with many parts of the country, I expect most of the private hospitals shut down, didn't do very much. And when they opened back up again, they had quite lucrative NHS contracts to try and deal with waiting lists. And what resource they had left over, they quite understandably were putting towards their biggest, highest bidding items. So we're back to joint replacements and other procedures. And varicose veins was very much at the bottom. So in fact, there was nowhere for us to treat these patients. So at that point, I thought I really had to do something. And I was actually lucky because I seem to be on a slight theme of orthopaedics here. But a senior orthopaedic surgeon in the city, I was talking to him, and he very kindly, this is Ronan Tracy, he very kindly let me use a room in his premises, which I was then able to adapt to a CQC standard in order to provide these treatments and apply for CQC regulations. So it came from the kindness of an orthopaedic surgeon and trying to work out how to develop a practice and restart a practice after COVID.
Well done. That's a big undertaking. Are you working with colleagues?
Absolutely. I mean, I think everything I've said so far, I think I've mentioned people in it. There is no way that I could have done all this without people's help and inspiration and support and advice. Whether it be Andrew and his team at the beginning, watching what they did and how they developed the service, and I still receive advice and support from them to this day about how to set things up and keep things going. Some of that original team worked with us. Our senior nurse, Gareth Bate, is a member of that original team, and there's no way that we would have this service set up without his support and help. And I work with a number of other consultant colleagues. So my colleague Donald Adam, Massimo Vizzosi, they're both integral in this. I had another colleague, Hossam Nasser, who's suddenly gone overseas, but was a great colleague to work with too, and I think is doing extremely well where he now is working in Saudi Arabia. And as well as that, we're opening up further and are looking to work with colleagues to make this happen. And we absolutely couldn't do it without the clinical colleagues. We also have a brilliant administration team as well that keep everything going. I think at times they must feel it's a little bit like herding cats, but they also are great with the patients, great with keeping the clinical staff where they should be, and great with keeping up with the administration and the paperwork.
Great. And you've got a very nice website. I don't know if I can share it. Let me see. Have you got anything to share? Have you got anything to share at all?
No, I'm afraid just to talk to me, I'm afraid. I can show you my website.
No, that's all right. I've got I'm looking at your website at the moment, and are all the members of your team on the website now?
The current ones are, yes. So you can have a look on there. Well, all the there's a little bio for the surgeons, but there's all. If you look along, you can see all the nurses that work with us as well, okay. and the administration team.
Okay. Let me just bear with me a moment. I'm always nervous about screen shares, Martin. In case I share the wrong thing. You know what I mean? But excuse me. I'm going to see if I can. Here we go. Yes. There we go. Good. Okay.
See if this is as easy as Microsoft Teams or harder.
Okay. Are we sharing?
We are indeed, yes.
Okay. So what I've got here, Martin, is your website. I'll tell you why I like this website. It's got the navigation at the top, which is very simple and straightforward. And let's have a look at your homepage. You say exactly what you're about. So if you've got varicose veins or thread veins, you're in the right place. Free consultations, Martin. Are they really worth it?
I think so, yes. But perhaps you might argue it's a way of differentiating yourself out from someone else who's offering your services in a different way. But we find we do get a lot of patients who come along and benefit from a free consultation with us. They're not sure, but they're worried about costs. They're actually often worried about what the treatment will be. They're still expecting to be told that they need to have a general anaesthetic and someone hack out their legs with a knife and then bandage them up, and then they'll be off work for 2 months, and so on and so on. So I think actually getting them to understand that the treatments are walk in, walk out, perhaps to be able to meet the team that would potentially carry out their treatments, allowing them to know exactly what it is they would be letting themselves in for, both in terms of exactly what the treatment is, the cost, the recovery time, I think is very helpful. I do understand that some of our other services would argue that it's not a good idea to offer free consultations, because what you wish for is patients that have made a commitment to come and have their varicose veins treated. But we genuinely find that most of our free consultations convert into treatments. Perhaps that's part of our admin team and patient advisor team who are able to work out at that point as to whether it's appropriate for a patient to come along to talk to us.
No, I like the idea of a free consultation. It allows people to come and see you and see where you're based and get to meet you and form a relationship. I like that. Do they get to see you, Martin, or do they get to see the nurse?
We have a surgeon-led service, and our principle is that wherever possible you will see the surgeon that will do your treatment and the nurse as well, but meet that team who will then perform the treatment as well and follow you up. The only time
even for your free consultation.
That's correct. Yes,
that's very good. Yes,
I mean sometimes obviously we'll flex that rule to suit the patient if they're in a hurry to have treatment or need an urgent follow up or some other reason. But that's our principle, is that it's all led by the specialist that will provide the treatment.
What I like about your website, you're not focusing too much on the treatments. You're looking at the conditions, and that's what people who land on the website are interested in. They want to know what conditions you treat, and they want to see if that's right for them. And you've got some testimonials and why they should choose you, and you're award winning. It's a great website.
It's not something that comes overnight, and again, it's lots of hard work on that website. Not done by me, done by my team, and it's a testament to their efforts as well, I think.
No, it's very good. What I like is at the header, you've also got your email address and your telephone number and a call to action, which is to book your free consultation. I really like it. Whoever's developed this is done a very nice job. It's a very nice website. And of course, you've got Meet the Team. And there you are. You look like a very welcoming team.
They're a great group, and they work very, very hard, and they are all expert clinicians who offer these treatments across all of their practice, and are proud to do so. So there's Donald Day, just see going past, who's been doing this for years, developed the treatment with Andrew Badbury, Massimo, who joined us more recently, but is another expert in keyhole techniques, and also there's all the nurses who provide these treatments with us, and also across the NHS as appropriate.
Yes, very good in vein conditions and the treatments. And the other thing I like about it is that you've got your prices very clearly published as well. So they don't need to ring up and ask that awkward question, how much are your treatments?
Part of the reason why we came out of the private hospitals as well is that we can offer a clear indication of what the price is without additional fees being charged for different reasons at different times to different places. So for us, we try and make it as simple as we can for the patient, in that there's a clear package price that would include all of the treatment, follow-up, etc. And as you've seen for varicose vein treatments, we offer free retreatment and a 12-month guarantee in order to settle people's mind that we're here to treat their veins and to deal with all of them at this point in time. Clearly, we can't promise that patients' varicose veins won't come back in the future. We know this is a chronic recurring condition. But what we can offer to do is to eradicate all the varicose veins in that patient's leg at that point in time.
Yes, I think that's very, very good. People want some reassurance. You can't guarantee that they won't have trouble in the future. Tell me, there's been a lot of discussion amongst people who are in private practice about the reimbursement that insurance companies offer. Does your heart sink when you get a Bupa patient?
So, again, that was part of the reason why, after discussion with my colleagues, we thought that we ought to see about moving from being just practitioners to becoming providers. To be blunt, yes, when we were practicing in the private hospitals, it was a break-even proposition to take on an insured patient and not do it. But at the end of the day, after you've often had to pay for your nurse as well, which is what we were having to do, pay for an ultrasound machine or the share of it, make sure that's updated and maintained properly, etc., as well as your indemnity, all these other costs that we all know about. There wasn't much left over to make it worth your while for doing these treatments. I have to say, I did notice one day, something that set my mind going, is that one day the insurance company unfortunately sent the bills the wrong way round. So they sent the invoice to the private hospital to me, and I got to see how much of the value chain, if you like, was heading towards the private hospital, and they weren't offering me an awful lot in return. So they were letting me rent a room off them that I was still paying for this, and it did set my mind thinking about whether there was a better way of doing this. So part of the process of setting up my own clinic when I received CQC approval was to then negotiate with the insurance companies and make them an offer such that we could take the patients directly into our clinics as a provider rather than a practitioner, which we've been able to do. And clearly with lower overheads and by working together, we've been able to make the pathway more efficient from both the point of view of the patient satisfaction, but also from a financial perspective as well.
Yes, I mean, it's quite an administrative burden, isn't it, getting approval from the insurance companies for your fees, your fee level, and then getting authorization for every little thing that you do, a follow-up, another injection.
So I think you've got to be reasonable with them, and I think that if you can do that and make it clear that you have good outcomes, and you can also potentially offer them package deals for the overall management of the patient, which the insurance companies can be interested in, then they will tend to look towards sending patients towards you. To be blunt, it's usually the bottom line dictates where an insurance company will recommend where you go. But there is a little bit of benefit that has come out of some of the CMA regulation and the CMA ruling. So, the Competition and Markets Authority, as we know, investigated private practice and had a look. And one of the points they made, amongst many of them, was that it was a bit of a closed shop, that there were not that many providers for healthcare, that it was difficult to get into and open into that market, and that there was at times perhaps a bit of an unhealthy relationship between insurers and private hospitals. So on the back of that, there was some advice given to say that insurers and the rest of the regulators should make it as easy as possible for other providers to open up and enter into the market, which is what we've done. And whilst that isn't always the case, it's all well and good to have some rulings put out where it might be slightly different what happens in reality. As a rule, actually, people tend to find that the insurers will give you the time of day and work with you. And I have to say that overall, whilst it can take some time, and whilst there can be quite long and arduous paperwork to be completed, overall they have actually been very helpful and supportive in us opening up these practices and recognising us.
Good, that's good. I mean, I've been out of it for a while. What is the latest on the once in a lifetime rule? I mean, how many times can people have vein treatment now, as far as the insurance companies are concerned? Is it one and done and that's it? You can't have any more?
Well, and I think the answer to that is there are as many answers to that question as there are different insurance policies with any particular insurer. I think that there is a move towards that. I think that looking at the overall spectrum of it, there is perhaps a trend now for insurance companies to say that we won't allow you to have treatment for your varicose veins if you've had treatment in the past, so they'll put that as an exclusion to a policy. A lot of them will say you can only have one treatment in your lifetime with them. But not every insurance company is saying that. Where we do find it interesting is in retreatment of patients. I think that most endovenous practitioners would accept that there is a retreatment rate. We feel it's somewhere in the order of 5 to 10% of the time a patient will need more than one treatment to successfully eradicate all the varicose veins. Our intention in our practice is to try and do it at one sitting, but we often will find that won't be the case. Well, 5 to 10% of the time we might find that isn't the case. And sometimes that can be difficult to get that across to the insurer that they need to support another treatment, which is where sometimes discussing with them around package deals can be helpful so they understand what their risk and exposure is likely to be. There are some insurance companies that will not support treatment for varicose veins at all, except in the case of ulceration and bleeding, which is perhaps very much along the lines of where the NHS is in many areas these days. There's a strong suspicion from a number of my colleagues that they think that the insurance companies are going to follow suit with what the NHS will offer in terms of varicose vein treatment, and that they're increasingly suggesting that varicose vein treatment is a cosmetic issue and nothing else. So
I made the decision to stop seeing any insured patients. I was a bit nervous about it. I thought maybe it sent a wrong message that I wasn't a Bupa approved or Bupa assured specialist. But actually, do you know what? It worked out very well. We just had to say to people, I'm sorry, we don't accept Bupa insurance or WPA or any of the others. And we were cash only. And that worked very well for us. So I'm interested to hear what's been happening since. And I'm pleased to hear that the insurance companies are being a bit more reasonable now that the CMA has got involved. So for everything, sorry, go ahead.
What I found was interesting is that it does work as a group, that the more senior of us in the group are definitely less preferred by the insurance companies. And there's really the only suggestion I can make is a pecuniary one to explain why that would be. But it does work well as a group. And I think it is quite important if you're going to work as a group that you can offer that, because if you plan to continue and have succession planning, you're going to bring in more junior colleagues, and they probably will have more interest in dealing with that part of the market than perhaps more senior colleagues might. My thoughts were always that private insurance, the proportion of the population with private insurance ought to increase. I think probably there has been a slight increase in that over the last couple of years since COVID, but really probably only in the southeast of England. So related to corporate policies, the majority of the increase that I understand in private practice, particularly in the West Midlands and the Midlands, probably relates to self-funding. So that perhaps comes back to what you're suggesting, that actually, I think you could probably have a very successful private practice without being reliant on insurance company funding.
So, Martin, you offer the full spectrum of treatment for superficial disease. You don't do venous stenting or no. So your endothermal ablation, you do foam sclerotherapy. Do you do phlebectomy?
So no, so I offer endothermal ablation in terms of radiofrequency ablation, simply because it was easier to set up than when using for EVLT for a laser. Although I understand that I think it's a bit more easy now these days to get a laser facility set up with the more shortwave lasers. But we offer radiofrequency ablation. We offer ultrasound guided foam sclerotherapy. We don't offer phlebectomies. And I'm aware of my colleagues that do that. And I think there are some advantages to that in the terms of it's perhaps a quicker way to get a flat leg than any other way of being treated. But we find that we're able to get very good results using foam sclerotherapy in combination with a radiofrequency ablation. And we also offer vein-like transilluminated microsclerotherapy.
Great. Now tell me, let's imagine a situation in which somebody comes to your clinic, they have a 7 millimeter refluxing GSV and some tributaries. What are you going to, and they're self-pay, what are you going to offer them?
Assuming that the great saphenous vein is suitable for radiofrequency ablation for endothermal treatment, that is what I would offer them. To treat the truncal reflux, we would perform an ultrasound scan at that point in time, so we'll see the veins in real time and be able to make that decision. And I would offer them ultrasound-guided foam sclerotherapy for the refluxing tributaries and varicosities. And our intention would be to offer that all at one sitting. So we see the patient, counsel, and then bring them back for that treatment all in one go.
Where do you make your profit, do you think? Where do you make your money in your clinic?
I think that we make money at every point, but we make profit in the main from offering the patient treatment packages and seeing them all the way through. So it's all about efficiency of scale. Seeing the patient, performing your own ultrasound scan, so you haven't got to pay someone else to do that or private hospitals to do that. bringing the patient back, treating them effectively within a reasonable time frame. So it takes us 40 minutes to an hour to treat the patient, having enough of the patients in a treatment list that it's worthwhile paying for the room rental and the ultrasound machine and the nurse and all the rest of it, all the equipment and the consumables, and then having a low retreatment rate, and being able to bring the patients back for follow-up that, again, if things have gone well, it doesn't take very long to perform. So I think it's the whole process that does that. But really, the major part of this would be being able to treat the patients on an ambulatory basis in a treatment room without all the high overheads of an operating theatre, a private hospital, etc.
Great. Well, Martin, I'm in awe of what you're doing. I don't know how you find the time or the energy. You've obviously got a very good team behind you or working with you. You're obviously very proud of your team. I note the language that you use when you're describing them when we were looking at your website. You're obviously very proud of your team, and you're obviously very proud of the very high standard of treatment that you offer your patients. I just have nothing but admiration for what you're doing. I know that you're coming to the British Association of Sclerotherapy meeting in May. A little plug. You're going to talk about how you actually do the clinical treatments and how you provide that combination of endothermal ablation and foam sclerotherapy to get the excellent outcomes that you do. So I look forward to meeting you in person and perhaps asking you some really tricky questions over coffee or lunch. But thank you ever so much for giving up your time. Is there anything else you think you would say to a they're all young now for me, a newly appointed consultant surgeon who's thinking about private practice? What advice, if any, would you give them? Would you say, well, whoa, don't go into it, or it's very rewarding? What would you say as somebody who's perhaps taken on a lot of work in private practice as well as your NHS? What would you say, Martin? I
would say you should definitely consider it. I think you need to be clear in your mind why you want to do it. I think you need to know in that buzzword, what's your North Star here? Why are you going for this? I think, and I think you absolutely should consider doing it. If it's in the field of varicose veins and vascular surgery, then be very clear in your own mind about what it is you think you could offer and how you would offer it. And I would definitely suggest that you get together as a group with some like-minded individuals and get in touch with the community. I mean, I've found it really helpful talking to people. They're very open, very honest about what the pitfalls and successes can be. And I think without it, I wouldn't have got to where I've got to. And I think that you'll be surprised about how much help there would be out there for you, were you to consider doing this. Make sure that whatever you do has the patient's interests at heart. You'll never go far wrong if you have that as part of your North Star. But take advice from people. I'm really looking forward to coming to the British Association of Sclerotherapists. I'm looking forward to giving the talk. I'm not looking forward to the difficult questions, although thank you for the prep on that. But I too get huge amounts of inspiration from the other senior clinicians that are there, from the other talks there, but also from industry, from all sorts of individuals. I think recently you've had Richard Oliver on talking on your podcast series. He's a real source of inspiration as well as other of his colleagues too. There's lots and lots of support out there, and I would go for it and use it and think clearly, but make sure you've got the time for it if you're going to do this, and you need to consistently have the time for it. The regulation isn't particularly difficult to do, but it is quite arduous, as in there's a lot of it, and keeping it going is a constant thing. So you need a lot of support around you to do that, and perhaps teaming up with a group of like-minded individuals is one way of sorting that out. Well, thank you very much, Martin. You've been generous with your knowledge and experience. You've been very open. I love your website. I like the way you speak about your team, the way you talk about why you want to do the best for your patients. It's all very, very good. And I look forward to seeing you in May. And thank you very much. It's a pleasure. Thank you very much. And look forward to catching up with you soon. Thank you. Yeah. Bye-bye. Thank you, Mark. Thank you very much, Martin.